they aren't there to notice when we might be struggling and could use a helping hand. And we aren't able to ask them for the kind of support that we need.
Welcome back to Longevity Roadmap. This is Buck Joffrey, and today we're going to talk a little bit about depression and suicide. But before we get our guest on here, I want to spend some time talking about depression is a chronic and insidious disease that has tremendous amounts of effects, not just on your brain in terms of your psychology, but just in terms of your ability to live a long, healthy, and happy life. It literally takes years off of your life. Let's start with the numbers. So a landmark study in the British Journal of Psychiatry in 2017 analyzed data from over 293,000 individuals and found that major depressive disorder, while excluding suicide, reduces life expectancy by approximately 7 to 11 years compared to individuals without depression. That's 7 to 11 years. For context, that's comparable to the life expectancy reduction seen in heavy smokers. A more recent meta-analysis actually was published in Psychosomatic Medicine that was in 2021. They suggested a loss of about 7.4 years for men and 9.7 years for women with recurrent depression. Again, huge numbers. Now, these figures hold even after adjusting for lifestyle factors like smoking, alcohol use, and physical inactivity. All of these things that you would think of, you might blame and say, well, that's probably why. So what's driving this? It's not just behavioral. As it turns out, it's biological. One of the primary mechanisms linking depression to reduced longevity is chronic inflammation. We hear that a lot in this space, right? In the longevity space, about chronic inflammation doing bad things. In depressed patients, we see a persistent upregulation of pro-inflammatory cytokines. Think IL-6, TNF-alpha, C-reactive protein. There was a study in 2020, the Lancet Psychiatry, showing that individuals with major depression have C-reactive protein levels 30% higher on average than their non-depressed counterparts, even after controlling for body mass index and other confounders. So this isn't a transient spike in inflammation. It is chronic inflammation, the sustained low-grade inflammation that we talk about, the same kind that we see in metabolic syndrome. And we know that it leads to chronic disease. Now let's zoom in on one of the biggest killers tied to depression, which is cardiovascular disease. The American Heart Association recognized depression as an independent risk factor for heart disease. And the data backs this up. 2019, there was a study in JAMA Cardiology that followed over 22,000 patients and found that those with depression had a 40% higher risk of developing coronary artery disease, even after adjusting again for traditional risk factors like hypertension and diabetes. Again, why would that be? It's likely chronic inflammation, because remember, there are two major contributors to coronary artery disease. We talked about the cholesterol part of this, increased numbers of ApoB particles. We've talked about that, but it's the inflammation in conjunction with those ApoE particles, right, that creates this cascade of events that leads to coronary artery disease. The inflammation causes an endothelial dysfunction, and that's where it plays its role. But there's more. Depression is also associated with autonomic imbalance, specifically reduced heart rate variability. And heart rate variability, we've talked about that before, basically more sort of sympathetic. It's an imbalance of the sympathetic and parasympathetic nervous systems, putting you more in a fight or flight type state. And when that happens, when you decrease heart rate variability like that, it increases the risk of lethal arrhythmias, like sudden, electrical things that happen in your heart that can lead to sudden death. So in fact, a 2022 meta-analysis in Circulation estimated that depression counts for, so all in all, when we look at that, at least from the heart, it's kind of summarized in a 2022 meta-analysis in Circulation that estimated depression accounts for a 1.5 to 2-fold increase in mortality from cardiovascular causes, independent of suicide. The impact isn't just heart disease either. You see the same type of data in diabetes, and then there's cancer. Not that depression causes cancer directly, but the 2020 review in Nature Reviews Cancer found that depressed patients have worse outcomes, with 20 to 25% higher mortality rates across cancer types tied to immune suppression and poorer treatment adherence. The moral of the story here is that we need to see depression not as a psychiatric condition alone, but as a modifiable risk for really all-cause mortality that's on par with smoking or obesity. It needs to be taken seriously and treated like any other disease. And again, I'm covering all the non-suicide related comorbidities. Again, I am discussing all of the non-suicide related implications. To discuss the other side of this, which is suicide. Now, as I said, all of the implications of depression on health span and lifespan that I've discussed today so far are independent of suicide. Now let's throw in suicide. And that is what our expert today, Dr. Peter Franz, will talk to us about after these messages. Welcome back to Longevity Roadmap. This is Buck Joffrey, and today my guest is Dr. Peter Franz. He's an assistant professor at the Furkoff Graduate School of Psychology. He has a PhD from Harvard and a BS from Cornell. His research broadly aims to better understand, predict, and prevent suicide and other self-injurious thoughts and behaviors. His laboratory uses risk prediction and prevention. Basically, it's a Ripple lab. Has recently been focused on developing accessible and culturally responsive interventions to prevent suicide in the Bronx communities and others like it. Welcome. How are you doing today, Dr. Franz?
Doing well, Dr. Joffrey. Thank you so much for inviting me. I'm really excited to talk about some of these topics.
Yeah, this is a little different from us. Usually we're sort of down in the weeds in a lot of the physiology and longevity science and all that, but it's an important thing, especially when you consider, especially depression itself has a significant impact on longevity, right? But
no doubt about it.
Yeah. So what inspired you to focus your research necessarily on this intersection of mental health, aging, suicide prevention?
Yeah. So I got very interested in psychology as an undergraduate, and I took a couple of courses, one on emotion, one on human bonding, and I was really excited by the idea that we could study the human condition and learn more about it and ideally optimize it so we could help people. But one of the things that started coming up as I started diving more into psychology is that there are a lot of people who are suffering, and they're all around us. And it's something that, as a clinical scientist and a psychologist, I care a lot about helping and alleviating the suffering that's going on. And so that really drove me then into the field of suicide research so that we could better understand and ultimately predict and prevent suicide.
So I mentioned, obviously, it's a big problem. How about in terms of just general numbers? How prevalent are mental health challenges? I guess in particular, I guess we can focus on depression, maybe suicide globally, maybe in the U.S., and ultimately kind of tell us how that impact manifests, because it's not only just suicide, right? I mean, depression causes morbidity in of itself. So would you talk a little bit about that?
Yeah. So mental health concerns are shockingly prevalent in the United States and around the world. Some estimates suggest that as many as 50% of all Americans will meet criteria for a mental health diagnosis at some point in their lives. Among those, the most common are anxiety disorders, followed by mood disorders like depression. And these have extraordinarily strong impacts, not only on well-being, but on longevity, as you alluded to. But I'm, in some ways, the most concerned about suicide. Over 49,000 Americans died by suicide last year. Over 8 million people around the world died by suicide last year. And so these numbers are really staggering and deeply problematic. One of the reasons they're so problematic is that, at least in recent years, suicide rates seem to be increasing. Yeah. And so we need to work to better understand this phenomenon and help the people who are at risk.
Are they increasing across the board, or are you seeing it in certain demographics more than others?
Yes. So one of the challenges is that 49,000 suicides in the United States seems like a large number, and it is a leading cause of death. However, once you start to break that up into smaller bins, the numbers get harder to work with and really identify whether our conclusions about the stability of those cell sizes are stable over time. But one particularly concerning demographic metric that has been coming out since the COVID-19 pandemic is that some minoritized youth, and in particular Black adolescent males, seem to be disproportionately increasing in terms of suicide prevalence.
Is there also an element there of, I think the aging and the elderly, is that a problem that's going up there as well?
Yes. So historically, at least in America, 65 and older has been the highest risk age group for suicide. And we think a lot about young people in suicide, and we should, because those people are at risk too. But actually, the majority of suicides are occurring in older people, and in particular, older men.
When you think about the things that might be actually increasing those numbers of suicide, what do you think about? I mean, obviously, we came off of a global pandemic, tons of loneliness, despair, but does your research kind of maybe speculate on what some of the reasons for those increases in numbers might be?
One thing that during and since the pandemic, and maybe even a little bit before, one big component of my research program has focused on loneliness and social isolation. It was a known risk factor long before I started doing this line of work, but our work has really clarified the extent to which loneliness and the feeling of disconnection from other people could function to increase risk for suicide. The flip side of that, though, also appears to be true in our research, which is that by increasing feelings of connection to other people, decreasing loneliness, we may be reducing suicide risk. And we can do that in fairly simple ways that I'm happy to talk about.
Yeah, and please do. I mean, what are some of the things that you can do? I mean, that seems to me like, loneliness and those senses of despair. I mean, especially after COVID, not just because of COVID. COVID itself had an isolating effect, but what technological changes we've had, like people not going to work and everything being online, to me, I mean, obviously I've not done any of the research, but I would think that, my gut tells me that that's a big, big problem that we're dealing with.
Yeah, no data that I'm aware of point to that conclusion in a very, very clear way. But I think that's because we don't necessarily have the studies yet to make this evaluation. Nevertheless, I would speculate that these effects you're describing are absolutely going on and maybe contributing to suicide risk. So when people aren't surrounded by others that they care about, a few things that are really important happen. One is that they miss opportunities for the kind of meaningful social connection that we have that increase quality of life and satisfaction, increase pleasure, which we know combat the effects of distress in a psychological fashion. But we also then miss out on opportunities for others to provide support when we need it. They aren't there to notice when we might be struggling and could use a helping hand, and we aren't able to ask them for the kind of support that we need. And so there's a lot of missed opportunities basically to gain social support when we are engaged in the same kinds of interactions that are rich in terms of facilitating social and community bonding.
So if social support, I guess, is a protective factor here, how do you create a large-scale change, especially when you're talking about focusing on a specific demographic like young African and American males?
Yeah, there are lots of things that people are doing in this space. I can tell you what our lab is focused on right now is developing a digital intervention that we call supporting well-being with everyday experiences of peers, or SWEEP. And the basic concept for our SWEEP intervention is to be able to share stories of lived experience with serious challenges, as well as recovery from those challenges, in hopes that people will feel less alone in the struggles that they're facing, and more like the struggles they're currently facing could get better in the future. So we're building social connection and building a sense of hope through storytelling.
Can you talk a little bit about like sort of the accessibility of that program? How do you get that out in large scale?
Yeah. The impetus for that line of research really came from the recognition that large-scale social media networks, people are discussing suicide all the time. And we weren't aware of programmatic ways to evaluate how that is impacting users, in particular, users who themselves are at increased risk for suicide. And so we just wanted to understand that phenomenon. So we started doing some research in partnership with social media organizations to better understand what suicide-related content might be, how it might be impacting people. But one of the really surprising things we found at first was that actually, in some contexts, that content can help people. And the contexts are when it's offered in a clearly supportive fashion, in a highly moderated internet social media network, and again, with the explicit intent to do good, to help people. And so we realized the potential power in that kind of intervention concept because it is so highly scalable. In the studies that we've run, it takes our participants less than 5 minutes to read and digest one of the what we call suicide recovery narratives that they're given. And we start to see fairly immediate effects in terms of the benefits of learning about someone else's experiences that are really hard, but that match yours. And also hearing that other person was able to keep going, was able to find recovery through certain means.
Interesting, because that's actually a fascinating concept. Just going back to your idea that people are talking about suicide on social media all the time, it makes me think back to, and again, these are all anecdotal things. Even when I was in high school, I remember in a few different occasions that it seemed like when there were suicides, either in high school or in college, they would come in multiples, right? Like almost these copycat situations, or like somebody saw that somebody else did it and decide they were going to do it too. And then when you put that on social media, that is like a huge amplification of that copycat effect. Is that accurate, what I'm getting at in terms of the negative side of the social media?
Definitely. So, and this really factored into where we were going at that time with this line of research. So suicide contagion is likely a very real thing. Suicides tend to cluster in time. So we see lots of suicides piling up within a certain time interval. We also see them clustering in geographic locations. So when there's a suicide in one place, people who are geographically linked to that place are at increased risk. And we see them cluster within social networks. Knowing someone who died by suicide increases your risk of suicide death, which has a bunch of important implications. But one of them is that on internet social media, people are more connected than ever. And so it amplifies, it increases the potential for contagion. And that's precisely what we were concerned about and wanting to understand how, like, the mechanisms through which that might take place. And in our research, even though it suggests there's some potential benefits of sharing stories, we don't want to ignore the fact that there are also major risks, and we want to be very, very careful about that.
Yeah, and it is fascinating. Just the idea then is the intervention goes almost like trying to inoculate people against this contagion. You would have to target those conversations on social media, whether it be paid ads or paid traffic or whatever. Is that kind of the way it was done?
What we're trying to do is to develop this resource that's very much like, it almost looks like a blog, a series of blog posts. And we direct people to that. And in the future, I could see this taking a bunch of different forms. One of which is that this line of research guides the way the social media platforms moderate their content. It doesn't seem, at least based on our work, that all suicide content is bad, but it provides some guidelines about what's good and what's potentially harmful. But we could also imagine a scenario where people who are experiencing all different sorts of challenges in their lives, whether those challenges are linked to mental health or not, find communities of other people where they can connect and share their stories, and that story sharing in and of itself is therapeutic in a number of ways. And so that, because of how brief, because of how low cost and how accessible this is, we think that this type of intervention seems to be pretty scalable.
I want to shift a little bit if we could, and I know this is not necessarily what your research is about, but I think it would be interesting for people to understand this, is what is the difference between somebody who has significant depression but does not have suicidal ideation versus somebody who actually does have suicidal ideation? And I wonder if you could bring it in the context of the physiology, because we do know there is at least in terms of suicides, there is some genetic element to this, right? So could you talk to the physiology there, a little bit of sort of like what's behind that?
Sure. But only a little bit, because it's definitely not my exact area,
Okay,
but I'm aware of some of this work. And from a genetic perspective, actually, it's been really hard to pin down genes that are specific to suicide. For one reason, suicide is relative to other events that we measure in psychology and psychiatry, it's very uncommon, even though it's a leading cause of death. And so that's made large studies where we attempt to isolate specific genes really, really hard to do. But one of the things that seems to be at least partially linked with suicide has to do with serotonin and the serotonergic system and the way that it is operating, which we also know, though, is linked with depression and a number of other mental health disorders. And so it may be that alterations in genes that encode, for example, the production or the binding of serotonin molecules in the brain increases risk for mental health concerns like depression, and through that mechanism then increases risk for suicide. But one of the other really big challenges in suicide research is that there isn't one cause of suicide-related outcomes, suicide attempts or suicide death. If there are 100 people who die by suicide, you might not only have 100 reasons why that suicide occurred, but within each person, you might have dozens of contributing factors. And again, because it is a relatively low base rate phenomenon, it's really, really hard to study all of this at the same time in a systematized way.
And I see that you're focused a lot on these interventions with support and that kind of thing. But what do you think in terms of medications, other interventions? What is your take? I mean, like, are we losing the battle in terms of, finding good medical, good medications, good therapies, that kind of thing?
Oh no, I don't think we're losing the battle at all. I think one of so there's a couple of problems here. One is that in psychology and psychiatry, we are targeting mental health concerns that are hard to conceptualize. They're very, very hard to measure. And so it makes it hard to get traction. Whereas if we were measuring cell count, for example, we can get an objective marker of the number of cancer cells in a particular region. There's no such measure exists for mental health concerns. We're often relying on self-report. And so that makes the work really challenging. But nevertheless, we have really good interventions that run the gamut from peer support to talk therapy, psychotherapy interventions, as well as different kinds of medications that all show fairly robust effect sizes and, in some cases, fairly specific effects for particular mental health concerns. And so there is great mental health care out there. One of the questions that we have is how do we help people access it? How do we reduce stigma around it? But there are good interventions out there for people, including pharmacological intervention.
So in fact, like a friend of mine who's a psychiatrist actually does a lot of ketamine therapy. And he says, he told me he's never seen anything like it in terms of people who are on the brink of suicide. The problem with that, of course, is that that's expensive. How do you deal with these issues? All right, you've got potentially, if my friend and colleague is right, you have something that can really make a huge difference in terms of changing, at least the immediacy of suicidal ideation. But it's an expensive thing, and that's obviously a challenge. How do you deal with all of that?
Yeah, I would argue that relative to the expense of loss of life, both in terms of its emotional and societal and cultural loss, but also in terms of the losses that are incurred by society when we lose someone to suicide, especially in a context where suicide in some ways really is considered a preventable cause of death. I might argue that the costs sort of pale in comparison.
Well, I don't disagree with you in theory. I guess the question is how do you get those therapies to the people who need them? Because they have to pay for them.
That's true, or insurance companies do. Right. And I think one step toward that direction probably has to do with very clear demonstration of the effectiveness of ketamine or esketamine, its isomer, in reducing depression symptoms and preventing suicide. And although these studies have really started to take off, to my understanding, we haven't amassed quite enough knowledge about how deep these benefits go, about how accessible this kind of intervention is, and about how broadly applicable it can be. Is it effective equally for all people? Are there particular concerns about who and when people should receive, for example, ketamine as an intervention? But yeah, my understanding is that both anecdotally from physicians who prescribe it and from the research literature, that some of these effects are remarkable, both in terms of how quickly they seem to take effect and how much relief people gain.
In general, as you alluded to, there continues to be, maybe less so than there used to be, even when I was 30 years ago, like in high school or something like that, but mental health stigma, right? This idea that other diseases are real diseases, mental health is in your head. That's a problem not only for those around the person, it's a major problem for a person being able to admit they have an issue that needs being addressed, right? So what are some of the challenges? What are some of the techniques maybe that people should know about that are out there in terms of, trying to erase the stigma?
One thing that I feel very strongly about in terms of reducing stigma, and I agree with everything you're saying, I think the stigma is very real. I do perceive anecdotally that it has reduced in time, and I hope it continues in that direction. But I think one really big force in reducing stigma at scale has been the widespread acknowledgement of the need for mental health care, a widespread acknowledgement of the reality of mental health concerns. Doing what you and I are doing right now, which is holding a conversation about real mental health needs and thinking about how we can solve them and putting this conversation out for the masses, I think these things help to destigmatize mental health conditions because it helps people to recognize one of the things that we're doing in our work, which is these are pretty common.
Yeah.
Emotional or mental health challenges are things that come up to varying degrees for all people. When I've done clinical work, I often talk to patients about how common it is to feel guilt or regret or sadness or anger. And the fact of the matter is those kind of psychological struggles happen for all people. And so I think recognition for how common these kind of challenges are through conversations probably goes a long way for reducing stigma. And we still have a long way to go.
Yeah, the numbers I've read just in terms of depression alone, gosh, I don't know how you even get your head around that, right? It's, what is it? Some people say it's maybe 8% of the U.S. population, stuff like that. But how many people, this is probably one of going to be the most under-recognized disease processes there is. Do you have a sense of like what real numbers might be looking like there?
Yeah, I don't know for depression specifically. And there's also a big difference in terms of prevalence at any given point in time or prevalence across the lifespan. But those numbers that you just described don't surprise me. I think one of the things to also consider there is that those numbers likely reflect people who meet a diagnosis of, for example, major depressive disorder.
Yeah.
And major depressive disorder has 9 very clear criteria. You have to meet 5 of those 9 over the last 2 weeks without remission to gain a diagnosis of major depression. And so the challenge is there are many people walking around, probably right outside my door right now, who have subclinical depression, only meet 4 out of the 5 symptoms, or they have those 5 symptoms, but intermittently. And those people are still suffering, and yet they might not be included in those figures that you just cited.
So just for the purpose of potentially helping somebody who's listening to this, what are those symptoms that you're talking about? And, you talked about 4 out of 5. Talk about some of the criteria.
So low mood, loss of motivation, poor appetite or overeating, the opposite, loss of sleep, or the opposite, sleeping too much, feelings of agitation, feeling like you would be better off dead. These are all some of the most common symptoms of major depression, and they tend to cluster together, forming this depression diagnosis. And again, each of those things could be experienced by any given person at different points in their life. But when they cohere together in a set of at least 5 out of those 9, and for a stable amount of time, that's what we consider major depression. And so that dividing line is really hard to clarify. But when people aren't feeling well, when people aren't feeling themselves, or they're feeling like they are feeling lost or sad or hopeless, I think those are reasons to ask for help, to check in with someone. And it could be as simple as getting a quick conversation with a primary care physician or even a loved one and thinking about the possibility of considering whether mental health care of some sort could be right for you.
And in terms of suicide, how can people tell? Okay, if maybe it's not them, if they themselves have suicidal ideation, that's pretty obvious. How can people tell if people around them, their loved ones, might be in danger of this? I mean, what are some of the signs?
Sure. I'll just say quickly to 100% agree with you. The challenge here is that suicidal thoughts, suicide risk is largely a private experience. And because of stigma and other reasons, it's really hard for people to share that. And so it's really tough to know who is definitively at risk for suicide or who is clearly thinking about suicide. That's hard for us to discern. The only way to really assess that is to ask people. That's a really hard question for most people to ask. Even for me as a clinician, it can be challenging. And it's certainly challenging when you first start out training and doing clinical assessments to ask these kinds of questions. But one of the things that I make sure to tell people is that for people who are at risk for suicide, being asked about suicide does not increase their risk. And so when we have concerns about people because there's been a change in their mood, or there's been a serious negative life event, like the loss of someone they care about, change in their employment status, etc., those are great times to check in and see how people are doing. And if you are concerned about someone's risk for harming themselves, it's okay to ask that and to couch it in the reality that the reason you're asking is because you care about their well-being and you want to make sure that they stay safe.
And if somebody says that they're thinking about suicide or they're considering it, what should you do?
Two things. I would first recommend that they get care and ask if they're seeing someone or if they'd be willing to reach out to that person. And second, if you are concerned about imminent risk, to ask if they're willing to go to an emergency room or to call 988, perhaps with you as someone they trust enough to have shared this information with you.
I guess we'll finish it off with this. Think about the research that you're doing, the research that others around you are doing. Anything that you're really excited about, think that has a lot of potential for, dealing with this problem in the coming years?
I think one really big thing that I'm excited about that many people, including myself, are focused on is how do we make our ability to identify suicide risk and our ability to provide interventions that reduce that risk tailored to the needs of an individual. As I mentioned earlier, every person who is at risk for suicide might be at risk for different reasons. And within that person, there could be dozens of reasons. And so it speaks to the need for really individualized ways to identify a person's risk and to mitigate that risk. And so we and my research lab and others like ours are spending a lot of time thinking about how we can personalize our risk assessment strategies and the interventions that we give people so that we can meet the needs of all people who are at risk.
Thank you so much, Dr. Peter Franz. It's good to have this information. Where do we learn more about your work if people are interested?
Yeah, you're welcome to check out our research lab's website. It's franzlab.org. That's the home of the Risk Prediction and Prevention Laboratory at Fairclough Graduate School of Psychology and Albert Einstein College of Medicine.
Thank you so much for being on the show today.
My pleasure. Thank you.